All right. Hey, everybody. Welcome to Monday. And that means it is a Monday coding and compliance roundtable. We started our discussion off with talking about weed. What was your discussion today? All right. So, with that said, I get to welcome all my favorite people to the program: Scott Kraft, Terry Fletcher, Paul Spencer, Stephanie Allen, Christine Hall. And that is in no particular order, just to be clear. How is everybody? Hope you had a great weekend.
Doing good.
Doing
good.
great.
You can't stop laughing now. Thanks, Sean.
Yeah. You might want to clarify that at some point, or maybe I will at the end. But yeah, we were talking about something that wasn't what you guys think as far as our listeners. Jeez.
It's a big gardening
It
conversation.
was definitely not about us smoking weed.
No.
It was we'll clarify it a
Contact
little
high.
bit later.
Yeah.
Well, not
contact-
anymore.
Yeah, exactly.
Before we get censured
I know.
from LinkedIn and all the other podcast platforms that we're on. So anyways, we're back after God, I swear the weeks just run together, the weekends just fly, and it's crazy. But here we are on the second day of October. It's impossible in my mind to comprehend that we're just 3 months away from 2024 and going into what I'm certain is going to be a psycho year, given that it's an election year. There's so many things up for grabs. And healthcare is going to be on the agenda. But with that said, Christine, I want to start with you because you had a really interesting situation. So I'm going to put you into the hot seat to get started.
You want me to talk about my Medicaid situation?
I do. I want to talk about what's going on down there in the state of Florida because Medicaid, even though we're talking about a specific state, Medicaid is a federally funded program. It's just administered by the state. So with that said, I think it's critical for everyone who's listening to understand that if one state has identified a particular topic and they are focusing on that, hyper focusing on that with audits, overpayment demands, clawbacks, it is not going to be long before it starts to spread its way across the country. So let me pause there and let me kick it over to you and let's talk about what's going on with Medicaid.
So I am in the middle of an audit where a wonderful, very, very small pediatric group received an overpayment letter with an extrapolation amount of over $250,000. And they did this because during the pandemic, or even during our state of emergency, the required authentication of a document is within 48 hours. Now, I'm trying to piece together how they're denying the service that was actually provided, especially in the idea that we didn't bill these services out until after they were authenticated. So they were reviewed, maybe they were waiting for something. It was a very short period of time that they exceeded that 48 hours, maybe another day or two at the most. And Florida Medicaid is clawing back all of this money that they provided to this little pediatric group. Again, tiny, tiny pediatric group. So for those of you out there that think it's not going to happen to me, I'm a little mom and pop. I got one nurse practitioner, one physician. It can happen. And like you said, Sean, if it's happening with some of these, I'd like to call them like minor technical errors. Also, they're clawing back all of their labs that didn't have a QW modifier, although they have a CLIA waiver and they paid the little labs without the QW modifier. They're clawing all of those back. And then again, like I said, extrapolating this back out to as long as they possibly can for every service that the practice has ever performed. And Florida Medicaid, we pay pennies on the dollar. It's not like we're California or one of the other states that I've heard recently that reimburse close to Medicare reimbursement fee schedule. We're really conservative in the state of Florida when it comes to that. So like you said, if it's happening here, it's really only a matter of time until others pick up on how much our program is recouping and they do it for their programs.
Yeah, to your point, the majority of states are paying pennies on the dollar. I mean, most states are somewhere around 70% of Medicare's reimbursed rates, which take out the potential for clawbacks and audits and investigations and just focus on the two main things that when I talk to physicians about why they don't participate with Medicaid in their state, the two number one reasons are first, the reimbursement is absolutely atrocious. But number two, and more importantly to them, it is the highest rate of non-compliant patients out of their entire population. So their outcomes are poor because of non-compliance. Their missed appointment rates are higher, which means, they're blocking appointments for patients who might actually show up. So again, Medicaid, I can't see that Medicaid is ever going to go away. It's just not. But what's going to have to happen is the federal government's going to have to intervene. As much as I hate to say that, the federal government is going to have to intervene, and they're going to have to find a way to stabilize the program. They're going to have to find a way to incentivize physicians to participate in the program, and they're going to have to incentivize, more importantly, beneficiaries to take a more active role in their healthcare to ensure better outcomes, because it is an unsustainable situation. So let me pause there. Terry, you're in California, and I know you've got your finger on the pulse with a lot of things that are going on in the healthcare space in your state. You know, Christine just brought up the fact that, California is one of only a couple of states that is very liberal when it comes to their reimbursement rates, and they're at a higher rate, closer to Medicare. And I'm guessing it's because of the cost of living index, for the state of California. But what are you seeing? I know your real focus is really the commercial payers, the SIUs, Medicare, but what are you seeing going on in the state of California from a Medicaid perspective?
Well, I think the big thing is that we have Medi-Cal, which is an HMO variant of Medicaid, and then we also have what they call straight Medicaid, which really only covers emergencies, hospital. You can't just walk into an office and say, I have coverage, which a lot of the people think they do. I think what's really tough here is our governor signed an order where illegals also qualify, which has been very expensive for the state. And so I'm not making a political statement. I'm just saying it's hard for me to understand, if you're not here legally, how you get funds that are only for legal residents. So in saying that, I don't think the fee schedule has anything actually to do with our cost of living. I think it has to do with just how much is allocated for funding. And it's very liberal here. I can't believe how much they put into that. But in saying that, it is helpful for who needs it. We have a very high percentage of children covered under that. And so I think in saying that, I think it's an important designation to understand that that's a positive. What's terrible, and I think this may speak to something Christine's dealing with and the rest of the country, is that when people are enrolled in Medicaid, it's because they qualify from a certain poverty level. And so you have to apply, you have to be eligible. Well, the PHE kind of messed that up. And I say that not in jest, but just saying that what the federal government said is that states could not disenroll Medicaid participants during the public health emergency. And so for any reason, even if they weren't eligible anymore, they still had it. Well, some people went back to work. So they had dual coverage. What planet does that make sense? Well, then as of this year, before the PHE ended, they said as of April 1st, now you had to be eligible, and the slowly disenrollment of people that weren't eligible happened. But then, of course, people are like, well, we didn't know. It's like, well, that's why there's commercials now saying, if you get something in the mail, you might want to send it back. I mean, that is a very simple commercial saying that you're still eligible or still apply. And what's happening is we have a lot of people that are still getting Medicaid benefits that are not technically eligible. So in my opinion, Sean, as much as I appreciate what Medicaid is, what they do, I think there's a flaw in the system about sympathetic coverage versus actual coverage that is for people who qualify. And
Yeah.
you have to realize that there are people out there that are struggling that can't even get to that paperwork that need to really have that. And it really drives me crazy because I just believe there's a lot of people that should be getting it that are not getting it. And there's people that are getting it that should not be getting it that have been kind of falling through the cracks. Just like people who are
Well,
still getting unemployment checks that went back to work.
yeah, well, I think you raise a really good point. And, I always try to keep up with what's going on around the country, you know, outside of just my state of Georgia where I live. And it's really interesting to see how a lot of these, a lot of states, specific cities within those states that have declared themselves as sanctuary cities are now saying that it is an unsustainable situation. Again, this has nothing to do with politics from my perspective, okay? It is an unsustainable situation. I mean, take a look at Chicago as an example, Paul, right down the street from you in Milwaukee, right? Just straight down the interstate. Um, O'Hare Airport has now become a living quarter for all of the illegal immigration that has happened where they have found themselves being transplanted to Chicago. Governor Hochul in New York has come out and said, "Hey, too many people are coming in. Our healthcare system is flooded. We don't have the funds for it." Again, to um, Terry's point, Medicaid was created for a specific population where there was socioeconomic challenges to these deprived individuals in both rural and urban areas to where it was medically underserved or a health professional shortage area. And now, with the influx that we see and what the public health emergency has created, we're finding more and more areas becoming these difficult situations, and Medicaid is not going to be able to sustain. So, I think, Christine, one of the things that you had said is, look, the Florida fund is all but bankrupt, and they're trying to find a way to replenish it. And they're doing that the same way that Medicare replenishes the trust fund, which is through audits and clawbacks and looking at these hypercritical, situations to be able to draw more money back to it. I
Sean,
want to go over to Scott Kraft for a minute.
can I ask you a question
Go
real
ahead,
quick?
Terry.
I wanted to ask you something because Christy and I had a chance to text and talk about what her situation offline a little bit. And you, as somebody who's a defender of guidelines and policies and things, this is actually a great topic. So my suggestion was because they're trying to take money back based on the fact that it wasn't signed within 2 days. My question was, well, was it billed? Because I understand if it was billed and it wasn't signed, because there's a signature rule, then it is considered an incomplete record. But if it wasn't billed and wasn't submitted, reported, whatever you want to call it, until after it was completed, because sometimes they wait for labs or they wait to close it so the doctor can review it, and maybe they just couldn't get to it till the third day, which I don't like that either, but let's just, for argument's sake, if they waited till it was actually signed, regardless of what the timestamp says from when the rules are, how is there how do they have a legal leg to stand on saying that they can get money back? Because there's no violation there of the rules. They submitted a
Right.
claim
Well,
that
it's a
They're
closed.
technical
quoting a
violation.
record-keeping rule, and
That's
there
right.
isn't anywhere where we see the wording that says that you're ineligible for reimbursement. That wording doesn't exist, but they
Yeah.
continue to quote that is the record-keeping rule.
It's just weird to me because if the claims were submitted correctly with a signature, closed out, authenticated, then I understand there's a record keeping rule, kind of like the CLIA waiver modifier. It was left off. That's terrible and it shouldn't be, but that doesn't have reimbursement issues. Like let's say you left off the FS modifier for shared visits. That does. That's a difference between, potentially 15% if it was, performed by a mid-level versus a physician. But whether you have on that waiver or not, if you have a valid CLIA waiver, it's a clerical error. So to me, I think they're getting around policy to try to get back money because they have a depleted fund, not because there's really issues going on.
So interesting enough, and then I want to go over to Scott and Paul and Stephanie. Interesting enough, there are state laws that have been enacted by the legislature that actually require medical records to be signed within a certain period of time. Like, I'm just going off the top of my head right now, like Alaska. I don't know why Alaska popped in my head, but they have a 72-hour rule, which states within 72 hours of rendering a service to a beneficiary, the note has to be closed, which means it has to be authenticated with a signature and a date. Now, that is a legal requirement, but now we're talking about a billing requirement. And the argument that I've heard several attorneys make in administrative law judge hearings and in federal court cases is that, listen, we're talking about a technical violation. It doesn't mean that the service wasn't rendered. It doesn't mean that the service wasn't medically reasonable, appropriate, and necessary. A signature. And one of the best arguments I've heard put forth during an ALJ hearing was, listen, anyone with a physician's credentials for logging into the system can sign and date a physician's note. Doesn't necessarily mean that the note was closed by the physician or the NP or PA. Could have been done by any member of the team who has access to the physician's credentials. Now, I know we're getting into a whole other discussion about HIPAA, and I'm not going down that road right now. But I want to go over to Scott, because Scott, you live in Washington State, but you also lived in Portland, Oregon. So you lived in two states recently, not including living in, Virginia, the Commonwealth of Virginia, and working in Maryland and blah blah blah. But
I've been around.
you've been around. You've been around. What are you seeing as some of the the things going on in both Oregon and in Washington State with Medicaid?
To be honest with you, I hate to say it, but I have not a huge client base up here, so I don't do a ton of work Medicaid specific in these two states. I know that being both, they are both cut a little bit closer to California than Florida in terms of access and access pathways to Medicaid. Certainly, both as part of the expansion of Obamacare and through the duration of the PHE. Payment wise, unfortunately, I think Oregon at least a little closer to Florida. Oregon kind of splits the difference. One of the things that is a reality up here, I think, and is probably in a lot of places, like there was a massive expansion of access during the PHE. Scaling that down and out has been problematic. Problematic from an access perspective. And certainly the clients that I do have up here, we have seen that through our work. But one of the things that I've noticed in a lot of places that I've worked, and one of the things I wanted to speak to here, and I think it's common in life, probably common in an overregulated life, is like, there are so many idiosyncratic or silly administrative rules. And this is not the first time in my work, ironically, that I've run into the Florida 48-hour signature rule, which doesn't make a lot of sense. But whether we're talking about like parking meters or restaurant licensing with tables on the streets, whether we're talking about HOAs, right? Like the world is full of crazy rules and people who make a living enforcing crazy rules. And for the rest of us, we're kind of stuck in the middle where we're just kind of like, can we do things like in a rational way that makes sense? Where, to I think Christine's point, if there's a modest administrative violation of the 48-hour signature rule, it doesn't mean that the patient's care was substandard. It just meant that somebody didn't get to this record and sign it within that certain amount of time. And, I hate to say it, but one of the pieces of guidance I just gave on the provider education call I just got off of is we were talking about a TPE audit that provider had, and a very technical finding about the documentation of the discussion of alternative potential therapies prior to doing like a minor podiatry like nail surgery. And my question for them is like, did you have the conversations? Yeah, we had the conversations. We just didn't do as great of a job of documenting it, and it really didn't affect the standard of care. But this was just something that reviewer grabbed onto and used it as the basis for this entire administrative review like process. And so, one of the things we all have to do in our work with regard to the specific states that we operate is look at those idiosyncratic rules and make sure that we have a pathway in place to follow them. Because I hate to say it, right? Like the easiest solution is make sure there's a workflow in place to sign the charts, because we can take these charts into a hearing, we can appeal these things, and that's probably what you're going to potentially have to do here. Part of it is just what are the random laws in my state, and how do I follow them? Because we all have them, right? Like we've all got these things, and part of what we're trying to prevent is we have to, much in the same way with the HOA, it's like you can't put your pumpkin out until October 1st, right? Like it's just avoiding the headache and hassle of these irrational things.
No, I think that's very well said. Great points around. So Christine was talking about, the auditing of the laboratory services and specifically the QW modifier. But I want to stay on the topic of laboratories. And I want to go to Paul and talk about what's going on with these large laboratories who are creating these panels, and providers are having to bill the panels that are being created by these entities. Otherwise, they don't get their services, their specimens processed. So, Paul, talk about what's going on right now in the laboratory space, because between UDTs and, the other type of lab services that we are seeing continuously being targeted for audits, it's become a very high risk audit area.
Well, to give you a little bit of background as to where I came from, in 1996, I was working for what was then SmithKline Beecham Clinical Labs. At that point, they had just been fined $300 million by CMS for unbundling panels as a matter of course and billing them out as individualized tests. And in my short time there, as they were evolving into Quest Diagnostics, I helped write their billing compliance protocols. I mean, this goes back 27 years. It's at least 3 kids and 1 marriage ago. But when we put that together, it was hoped that those billing protocols would be fixed. And lo and behold, many years after I left, about 2010, they got fined again for similar behavior. Now, the focus right now on the larger labs, and it's not just the Quests and the LabCorps of the world, but it's also large hospital-based laboratories that provide unusual laboratory services. And you can think of large hospital systems like the Mayo Clinic that do large-scale cancer testing and have created their own panels in order to speed up that process. For many years, the FDA has kind of exempted them from proving that those tests are effective from testing, because the argument has been, well, these are very serious tests, and to put them into a testing protocol at the FDA, taking many years in order to validate the results of a given test, that would put the diagnosis and treatment on pause for a number of these patients. Well, there are a few different things that are happening with regard to testing. And I think one of the bigger things that we've been seeing, Sean, are the issues with UDTs. But most importantly, coming out of COVID and some of the testing that we saw there, we're seeing that there were a lot of companies that were creating COVID tests that just weren't effective or were not giving correct results. And then we tie that into the train wreck that was Theranos and their CEO and their CEO now being handed long jail sentences for basically falsifying the fact that no, you can't get a laboratory result from one drop of blood at your local Walgreens. It was falsified. So now they're taking a renewed focus on some of these laboratory services.
Well, can you quickly talk about, since we're on these laboratories, because you and I have had several interesting cases together this year. One of them that came up was something called BioFire. And that was a lab test that has drawn a lot of scrutiny and a lot of interest. Can you talk just very quickly about what BioFire testing is?
So BioFire is a company that makes a CLIA waived testing cartridge that in the middle of COVID, they redesigned in order to test a number of different respiratory variants to look for viruses and other types of bacterium. The issue was, pardon me, and remains that a number of doctors' offices, rather than using a PLA code, a proprietary laboratory analysis code that is created specifically for that machine, they were just choosing all the CPT codes for the respiratory variants that were being tested by that one cartridge. Big no-no, particularly if you're not billing it with a QW modifier, because that machine is sitting on a counter in your office. And we have an opioid crisis in this country where suddenly pain management physicians are being asked to pay back tens of thousands of dollars in drug testing that is valid and that is prescribed by their state in order to make a determination as to whether their chronic opioid therapy is working efficiently. And at the same time, here we have large labs and academic laboratories and hospital-based laboratories who are billing tens of millions of dollars in cancer testing. Just to throw a little bit of a curveball on this, just to personalize it a bit. And I know Scott knows this, and it'll come as a bit of a surprise to the rest of the panel. But about 69 hours from now, I'm going to have a bone marrow biopsy. And the results of that bone marrow biopsy are incredibly important to me, and the labs need to be right because it's going to direct the testing and the treatment that I might have to go through after they test that sample, and it goes through the different protocols, and the determination is made as to where the treatment is directed. And it's very important to me as a patient that it's correct. And I'm hoping that the FDA takes a very solid look at some of the testing that's going on and making certain that patients like me are getting results that are correct.
Yeah, there's no doubt about it. And, obviously, as one of my personal friends and a colleague, obviously, my thoughts and prayers, and I'll be keeping you on my mind as you go through that bone marrow biopsy. And I'm sure everything's going to turn out to be just fine. All right. On a more upbeat note, let's go back to Terry for a minute, because I want to talk about supervision, but I want to talk about supervision from an interesting perspective. And I don't know if there's an element of laziness or if it's a fact of people have gotten so comfortable with the relaxed requirements of the public health emergency that we still have a lot of providers wanting to render direct supervision from their home. But that's not direct supervision. So, or they're what they're calling virtual supervision, which better translates as general supervision. So Terry, go on, take it away.
Well, this has been an ongoing sticking point for me, especially at the post PHE. So something everyone knows that telehealth is. I've been teaching telehealth and educating people on it for almost 20 years. So I know that a lot of people didn't even know what telehealth was until the PHE. And so that's where it's a little bit confusing for people, because I know Christine and I both taught on telehealth, and we say, so pre-PHE, and they're like, what happened then? They don't even know what originating site or distant site or any of that was. HRSA, all that. So it's been a challenge because people only know the public health emergency rules. And so what happened, and this is funny to me because I figured, you know what? I know everything there is to know about telehealth, even all the PHE rules. Then I was reading the repeals and the pullbacks, so as they were easing the rules on this, and I read during the PHE they allowed for virtual supervision, for incident to and for certain testing. And I'm like, they did? I didn't even know that because my clients were not engaged in that. And I was not wanting to know that. But I was just like, okay, that's really weird. So in my mind, now I'm going to age myself, all I could see is, wait, okay, explain how that works to me. Is there like a little CP30 from Star Wars walking around with an iPad in everybody's office with a doctor's face on it, in the office, where it can say they have to be in the clinic, making sure everybody's doing what they want as the doctor's at home watching Top Chef and, just looking to see what everybody's doing. And it was weird to me. I just thought this was so ridiculous. And then I saw they allowed it for critical care during the PHE and they allowed it for teaching hospitals. And my head exploded, literally. I was like, what are you doing? And so then they rolled it back and now it's only good through the end of 2023. But to Sean's point, my issue with this is, first of all, CMS in March said in their post-PHE webinar, and I keep this quote on my desk. It says, discontinue the use of waivers when no longer needed. We are no longer in a public health emergency. So what are you doing? And I know that the final rule proposal, it wants to extend it to 2024, but right now it's 2023. That isn't in stone yet. And so, but it's ridiculous to do that. Why? We're not in a public health emergency. For all argument's sake, the pandemic's over. But here's the problem. And this is where I think it gets really messy. So one of the rules for crossing state lines, and I've taught on this so much. I mean, I think I presented 3 times from NAMIS and every possible APC chapter on if you're a physician that sees a patient outside the state, can you see that patient still bill it out? Well, no, not in a lot of states as of 2021 because they repealed those waivers. But in 2022, CMS came out and said you absolutely cannot supersede what the states say, and they tell us this 2 years after, both presidential candidates, crossing over said that, oh, you can see a patient in Florida if you're in New Jersey. They didn't say make sure the state says it's okay. So for 2 years there were a population of physicians doing this wrong. Well, now fast forward to where we are now. What the rule says post PHE, again, all those waivers, or I would say 99% of them have gone away, and you have to be licensed in the state where the patient is to be able to bill it out, and the doctor does. So here's the caveat that I'm getting. So a doctor says, okay, well, my patient is in Illinois. I'm licensed in Illinois. But I've decided I'm going on vacation, not the patient. I'm going on vacation to Arizona. And because virtual supervision is still allowed through the end of the year, I'm going to still get this on my virtual supervision. I'm still going to bill it incident to. And I'm like, no. First of all, it doesn't qualify because if you're not in the state that you're licensed and you're not licensed in that state, then you right out the gate, you don't qualify. You're not licensed in the state that you're now, it's going to be billed under your licensure and you're not licensed in that state. And he's like, well, where does that say it in writing? And so I pull up the state. You have to be licensed in that state. Yes, but I'm licensed in the state where the patient is. I'm like, you are mixing up PHE rules and licensure rules. Licensure rules said you have to be licensed in the state that you're treating. And if you're billing it under yourself and you're not in that state, you're not licensed in that state. And it's like this ongoing battle. And I hate to say the word laziness, but I mean, that's just kind of, I feel like where we are. And I don't know, I'm just getting very frustrated because I'm seeing liberties being taken again with PHE rules. We're post PHE, even though some, reports say that there is a slight uptick in COVID, but why test at this point? It's just like the flu for some people and we have everything we need for it. But I don't know how to, and I shouldn't feel like I have to, argue the point of doing things right. I don't understand why we are always arguing to do what's right and to not push the envelope like that Price is Right cliffhanger game. You know, you hear the guy going yoda yoda yoda, goes up
Oh,
here,
the
and
yodeler.
and he almost falls over, and if he does, you don't win the prize. But the doctors seem to want to push it all the way to the top of that cliff. And I don't know, Scott, I'll throw it over to you. Do you see anything in this space that drives you crazy? I see it all the time. It drives me insane.
I mean, it's that. What drives me crazy, I think, to your point, is it's we had like a defined public health emergency period. Now, I would probably argue that that defined period lasted longer than what was sort of the logical scope of, when you go back to March 2020 and all of these accommodations are coming out. These accommodations are coming out on the basis of, from everything we know right now, right? Like if I slide up next to somebody, like I might kill them or they might kill me, and we don't really know that, right? Or the patients take on all this risk. And at some point we kind of realize, well, that's not exactly the case. But we still have this PHE federally that drags out well beyond the scope of all these state PHEs. And I have been knee deep, Terry, in clients we work with who are proximate to state borders. I mean, as Sean said a little while ago, I used to live in Portland, Oregon. Now I live in Vancouver, Washington. That move was like 8 miles, and I crossed the state border and I entered like a whole new world of like laws and regulations. And we've been navigating all of these things. What gets to me, to your point about pushing the envelope, is I have clients asking me now. So I want to start doing virtual supervision. How long can I do it for? And what's the current status of the rules? And I mean, look, if you asked me as a taxpayer or whatever I am in our society, like at some point we should have just said, if we're ending the PHE, we're ending all of this stuff. We're not ending
I
it for
agree.
this, and then you can do this other thing until the end of 2024, and you can do this other thing. I mean, if we learn things during the PHE, like I think we probably learned that there's some rational basis to offer telehealth to Medicare patients without those patients having to be located in some originating site. But I think we're past the point where we need like a supervisory physician who's remotely in one location supervising an incident to service for somebody who's in the office. I got a question last week, and the question was, I hope they're not listening. The, they, the doctor was worried about catching COVID. So he basically wanted to know, could he have the patients visit the office and he would treat them remotely from his office in the clinic?
Oh my
And he
gosh.
wanted to bill it as a face-to-face service. And so those are the kind of things that we're
Um,
having come up, right? Like, I can't even, I'm going to start laughing. But yeah, the basic question was, well, the patient can come in and take on whatever risk they're willing to take on. I will come into the office, but instead of going into the exam room, I will go to my office and I will render the service face to face. Can I do that? And so I, I don't know if this is a helpful answer, but this general concept of envelope pushing, in some respects, has been a theme on two sides of our conversation today. One side is we have irrational regulators pushing these rules on us to make it seem like I'm pushing the envelope because the provider signs a note 60 hours after the visit instead of 48. The flip side is like pushing the envelope in things that we really have no basis point in October of 2023. We are literally more than 3.5 years since the start of COVID to be pushing the envelope for these things where, I mean, look, I mean, you walk out in society, right? We are pretty much back to normal and everything else. Like if you can go see a concert, if you can go to a sporting event and sit around 70,000 people, we probably shouldn't be asking these questions about virtual supervision, because to me, when you're asking that, you basically know you're pushing the envelope, right? You're like, well, how can I provide incident to supervision across 3 offices instead of one if I just sit at my house? And it might have been a fair question in April of 2020, but it probably isn't one now.
So I want to go to Stephanie real quick. Um, and two things. I want you to talk about a little bit more of what Scott was just addressing, but correct me if I'm wrong. Didn't we at one point earlier this year have a client that was purchasing robots that actually had a computer screen and the provider was going to be on that computer screen as the robots went in and out of the rooms, and they were going to charge for in-person visits at these sniffs or something. Am I making that up in
You
my
mean my
head?
You're
Because I
half
seem
right.
to remember that conversation.
R2D2 was correct? Oh, no.
No, you're
Jeez.
half right.
Oh, wow.
Imagine going to the doctor and like
Well,
Rosie's
listen,
in the
at least I'm
chest
half
and-
right.
You're mixing two client situations we had. So the robot
Oh,
one,
okay.
they're not doing it to bill. They're doing it because they're concerned that the nurses are not able to do the job they're supposed to be doing. So they're not billing for the robot, but the robot is intaking information they need from their patients to make sure that they're addressed when something's wrong.
And if I'm a patient, I'm definitely talking to the robot. That's all I'm saying. I mean, you know, that I know that that's not going anywhere.
Not happening. Not talking to the robot.
Yeah, it's going in and asking patients how they are every day. Well, I think every day. I don't know
Are
how
you
often.
serious? There's actually
Yeah.
a robot doing this.
No, seriously, this
Oh,
was a
for
real
crying out
thing that
loud.
was going on. And listen, to
It
tie
doesn't
that
freak
together,
grandma
and
out?
Stephanie, yeah, and then Stephanie, I just want to say this one thing, and I want you to go back to
Okay.
what you were talking about. So last night, I actually got a chance to watch Mission Impossible 7, Part 1, Dead Reckoning, and it was all about artificial intelligence, right? And this whole thing about how, anyways, if you get a chance, it's a long movie for a Mission Impossible movie, but it was interesting because it gave you a whole different perspective on artificial
I've
intelligence
seen it. Yeah.
and really how these things are coming into play. Not going to say it was good, bad, great, horrible. Make up your own mind on it, but it was definitely interesting. All right. Now, back to what really matters. Enough about Tom Cruise. Let's get back to what really matters, and let's talk about what Scott was engaged in before.
Yeah. So one of the things that, and now this is the other half, Sean, that I think you were mixing with it. We had a situation where a client was doing virtual supervision just due to the rural areas that their clinics are in. And they were using it as a way to have that oversight that's needed. And in their particular state, they could use, it was infusion services, they can use NPs to oversee that particular service. Now, one of the things that's happening and that I'm finding, and one of the things that concerns me based on like what you were saying there, Scott, how many times have all of us seen throughout the PHE people going in and using these waivers as a new business model? And when I hear all of this talked about, that's what it sounds like to me, because I don't necessarily see people always using it as a convenience method, but I see this and other things being used as a way to bring in more patients or put more services through their particular system. So, when all of this is being talked about, it's a very real concern with what Terry was saying is, why is this still necessary? And even if we think about what Christine started the podcast with today, we wonder why all of the payers are being so aggressive, and this is part of our answer. It's one of those things where a lot of conversations I have with physicians and providers, they're very frustrated with the current state of the industry. And if you have some bad players, it's going to ruin it for the rest of us. And this is just one of those areas when you keep pushing this envelope, keep trying it, set up new services, want to extend it for as long as possible, there's going to be issues. And one thing that I don't think we've really talked about yet today is that this is all a CMS waiver and concept that we're talking about. How do you know within your particular state that your commercial payers are going to be following the same thing? Now, with that being said, I've had some situations I've had to defend some clients on where I went into the state and what the state was guiding the payers and what they were dictating payers in their state had to do. During the PHE, it did go back to CMS guidance, but people are looking at waivers and they're just saying, oh, I can do this for everybody all the time. And the reality of it is we're getting these aggressive audits from payers. Even if, like in Christine's situation, they don't have it in black and white writing, it still leaves us in a situation where we somehow have to pull information to support and defend. And how much money does that cost? How successful are we going to be when it's still their call at the end of the day? So we have to stop looking at things as a new moneymaker, because it's what's going to get you in trouble.
And
Yeah,
it's
I
going to
agree with
ruin it
you.
for those that need it. For, like you were saying,
That-
Stephanie, there are some great benefits when this is done correctly, but we've got bad actors out there who I hear all the time, but we get paid. We can do this minimum amount and we get paid, but now it's ruining it for everybody else.
I think the thing I would add is, and I alluded to this before, you know, to me, like not just in healthcare, but in life, like the craziest thing that we realized when COVID first started was we had this entire infrastructure of regulations that we just swept them all to the side, right? We're just like, well, now we can do it this way, right? Well, we're in an emergency, so now we'll just forget all these rules. We'll just do it this way. And I think along the way, a lot of us realized probably in a lot of different aspects of our life, well, okay, we didn't really need to operate in this manner over here, but this was what the law required or the regulations required. We quickly learned how easy it is to do it this other way. Uh, it, but the regulations didn't go away. And whatever your business is, whether it's you're a healthcare provider or you operate like a diner or whatever that happens to be, you have to exist under the regulations that are in place for the place in which you operate, whether that is a state Medicaid policy, whether that's a federal healthcare rule. And so this idea of sort of, well, we can play last fast and loose with the rules because we did it, this other way, is just a recipe for trouble. And I mean, I think we could go back to where Christine started with the signature rule and how, there's not a lot of rational basis for the level of enforcement of scrutiny that that client is facing. And there, I'm sure that that's going to be, you're going to push back on it and you're going to fight on it in some way. But I'm reasonably sure if you went to that person and you said, well, don't you wish you had just signed all these within 48 hours, they probably would say yes. And so whatever envelope you're pushing, when you push it too far and you get that bite back of regulation, and you're going to find yourself saying, well, don't I wish I had just done it this way in the first place? Just do it that way now. Because we're giving you, and we can come back just about every week from our work and give you concrete examples of the person who got caught with their, hand in the jar, so to speak, not maliciously, but there was some regulation that they tried to end around or work around, and it didn't work out. And you just there's just there's no business benefit that I can think of to doing it that way when, I think any business you talk to would tell you, regardless of the industry that they're in, that there's irrational things that they have to do to follow the laws of wherever they're operating, but there's real implications for not following those things. And it's no different in this conversation, really.
Well, I think also what people miss, and I think this is just kind of a general concept on things, habits are hard to break. And I think that, and there's kind of a hidden rule out there. Anything you do for 2 weeks is considered now a habit. It's like if you're on a diet for 2 weeks, it gets easier after that. That's why most employers don't allow employees to go on vacation longer than 2 weeks, because then they'll never want to come back. They're used to being off. And that's why I usually get, no more than 2 weeks at a time. Think about DoorDash and all the apps to, get food and, delivered to you. Let's face it, that food's pretty much cold when it gets to you. Very rarely do you always get the order you want, but it's so convenient. It's so easy to do. And I don't want to say it was a necessity during COVID, but it definitely was a way to change things up. And now, and there was even statistics on this from the, restaurant association saying that about 18% of America ordered in before COVID. And then during COVID, it went up to 81%. Oh my gosh. And post PHE, it's still at about 60% level. So people are still doing it, even though they should get off the couch and, go to a restaurant if you really need to go out, or go get your food. Not talking to my daughter directly, but just thought I'd throw that out there. So, it's just funny because I feel like a lot of these, you've heard the phrase setting people up to fail. A lot of these regulations have set people up, unfortunately, to, we're like Scott said, and like Paul said, and everyone said, that we've been in this, 3.5 years now, even though a formal administrative PHE ended May 11th. There's still these habits out there, and people aren't breaking these habits, which is a problem because you know, these habits are going to cost you your practice, and you're going to end up having to pay back money. You're going to have to explain yourself. Is one of the biggest things is the April guidance on post PHE from CMS on audio only phone calls that said, it was a third bullet. It was buried, I think, on page 8 of this guidance. And it says, you have to you have to document why the patient couldn't be seen in person or audio and video. And so, there's definitely some hidden guidance on why they're saying, why are you still doing it? And I think they started with that. And Paul, I'll throw it to you.
Well, part of this is CMS's fault, because reading through CMS's regulations, they give you what I like to call the obfuscated inch. They give you a lot of different regulations that are written in such a way that doctors who are not attorneys are looking at it and saying, okay, what is the limit here? And the caution I would always give you is, you never get in trouble taking the inch. It's when you start expanding beyond that inch to a mile is where you start getting into compliance problems.
What I find that is happening a lot is, I don't know about you, but when ICD-10 was postponed and postponed and postponed and postponed, and we all got very complacent. We were like, it's never going to happen. And now we have the final rule from last year that said, we're going to give you 151 days. And then the Consolidated Appropriations Act said, no, we're going to give you to the end of 23 on some things and 24 on other things. And now the proposal comes in and says something else. And to your point, Paul, if you're not an attorney, if you're not a compliance officer, if you're not in that higher position, the small practices, they have no idea. And until they get the letter, they didn't know they were doing something wrong, because frankly, it's changed so much that we're almost becoming that numb to, well, when am I really supposed to stop doing this? Right?
No, I think that's a great point. And, the longer things continue to be extended when there's no logical reason for extending them other than political expediency or whatever it might be, it just creates more chaos. It creates more noise. It creates more confusion. And the repercussions aren't against the government. They're not against the payers. The repercussions are against the providers. They're against the hospitals.
And
because
subsequently the
they're
patients,
stuck.
Sean.
Right. The patients suffer as well. But the medical practices, the providers, let's just say providers, so it's all encompassing, right? They're caught in purgatory because they don't know which way is up and which way is down. And they're stuck here in this middle. And then everybody's wondering, okay, is this going to lead to an audit? Is this going to lead to somebody making an allegation of impropriety against my practice and or myself that could lead to a whistleblower case? It could lead to an investigation. It could lead to a prosecution. So I think, we need some stability. I was going to say one thing about not DoorDash, because I don't use DoorDash. Uber Eats. I used Uber Eats in Seattle when I was out there getting ready to speak at a conference. And my food showed up, and one of the packages was partially opened. And I thought to myself, I'm not eating that. I don't know who this person was that delivered it to me. I don't know at what point the box got opened. I don't know if it was contaminated in some way, shape, or form. So I reached out to Uber Eats, and Uber Eats said, we greatly apologize for the inconvenience, but this order is not eligible for refund or for reprocessing. And I remember I responded to them saying, so what am I supposed to do with a box that arrived opened? I don't know where I was going with that. Anyways. All right. let's go around the horn because I want to have the last word today on something that I think each and every single one of the panelists can relate to, and probably a whole lot of our listeners. So I want to go last. So Scott, let me start with you first on some final thoughts.
Um, yeah, I mean, look, I think my final thought is, like I said a little bit earlier, we've covered sort of both ends of regulatory issues today. Like we've covered rational and irrational regulations. I think one of our responsibilities anytime you own a business, operate a business, is to have an understanding of the regulatory climate, what the regulations are in which you operate, and follow them. And it's like old Joe Friday used to say, right? If you don't like the law, try to change it. But if every healthcare rule was rational, the five of us probably would have a lot less to do. And so I think it's just something to keep in mind. Is it five of us or six of us? The six of us would have a lot less to do. And so I don't, I think that's important. I think it's very important to be cognizant of what you have to do. And the reality is, as a business, you have to spend money, you have to invest in resources to understand how to operate legally and compliantly in the environment that you're in.
Excellent. Stephanie Howard.
Okay. So my last thoughts would be around just thinking about how your practice is set up. So, if you're going through your day-to-day work or you're sitting there as a coder, an auditor, you're questioning what you're doing, think of it in the reverse way. Don't think about the way that you're getting this bill out the door initially. Think about how you're going to go back and defend that. And if it's something where you can't find it in writing, there's a really small section, it's very subjective, it's a gray area, you need to be thinking about how that's going to be changed going forward, or even what you're doing personally to those claims that you're pushing out the door. We've talked about that risk to staff in the past, personally, that you take on. But more specifically, when you're thinking about the overall risk of the practice, you want to make sure that what you're doing is not just defendable potentially. You want to make sure that everything's set in the current environment that we're working in.
Excellent. Terry Fletcher.
I would just invite practices to stop using the term "it's technically okay." I think that you have to be careful with that, especially if you're not on top of the information flow like all of us are. I mentioned that the audio only excuse has to be documented, and it's found buried in an April regulation. The fact that they're going to use timed claims, if you're using time to level your E&M service, they're now going to use an objective way to figure out if it's actually a believable day. That's buried on another published guidance. And why do you think the public health emergency was only extended on Fridays? They were trying to figure out if you actually noticed. So, they're baiting you. I truly believe that, and maybe you don't, but I think that there's issues there that you have to not just be technically correct, you just need to be correct. I hate it when somebody says, well, honestly, well, why would you start a phrase with that? Are you being dishonest the rest of the time and just today's honestly?
Dishonestly.
Oh my gosh. So yeah, so let's just stop being technically correct and let's just be correct.
Absolutely. Paul Spencer.
And if you don't know the answer, find somebody who does. I don't know how often we've been telling, getting back to Christine's topic, I don't know how often we've been telling practices that, yes, Medicare says that it's a reasonable amount of time between transcription, but 24 to 48 hours is really when you want to complete your documentation. And there are tens of thousands of practices out there that just can't figure out the flow. If you're having trouble, find somebody who can help you through that flow. Find somebody who can do a gap analysis as part of a compliance program that gets you to the point where every I is dotted, every T is crossed. And when you send out a bill, you're not chewing all of your fingernails down to the cuticles trying to figure out exactly whether it was compliant or not.
Excellent. Christine.
You reminded me of a saying that's one of my biggest pet peeves. Well, we've always done it this way, or they keep paying it.
Yep.
And
the 7 dirty words of a compliance officer.
Right. Like there's nothing that is the same. This industry is constantly evolving. I got a phone call this morning from one of the doctors who said, I heard that there was a new CPT code out there that I could be billing for this service. And I responded with yes. And when I presented it, all these changes last year to your practice where you were sitting, I went over this as well of what a great advantage this was going to be for your practice. You have to be involved in this a little bit. I think that it would be naive to think that you don't have to know what the rules are. Someone else is going to find those out, or they'll deny a claim and then you'll know it. You can reach out to any of us. We'll be happy to help you, happy to get you on track, happy to make sure that you're doing things correctly.
All right, I'm going to take the last word on this one today. For those of you that are not presenters and you are an attendee at a live session or on a webinar, be mindful of the feedback that you leave for the presenters. Because if you have presenters who read the reviews because they genuinely want to make sure that they are delivering what they set out to do, people take things to heart. And at the end of every one of my podcasts, I always say the same thing. Be good to yourself, but more importantly, be good to each other. If you have never given a presentation before, if you have never spent the hours researching a topic, building slides, putting a talk together to be able to deliver content to individuals who are either not willing to go out and do their own research, or they have and they need somebody to make sense of it. Be mindful, because a lot of effort goes into building a presentation, and it takes a lot of nerve, it takes a lot of guts to get in front of a group of your peers who are as knowledgeable, if not more knowledgeable in some respects than what maybe you are, to present on a topic. And if you're one of these people who just wants to see the earth burn, find something else to do with your life. Get a cat, take up knitting, find a hobby. But at the end of the day, don't be that person. All right. That's going to conclude this episode of the Monday Coding and Compliance Roundtable. I wish each and every single one of you well. Have a fantastic week. Terry and I will be back tomorrow with a hashtag Terry Tuesday episode. I know we have a good topic tomorrow. I'm really looking forward to it. And again, to each and every single one of y'all out there on the interwebs, thank you so much for tuning in, logging on, and just hanging out with each of us for a little while. Christine, Scott, Stephanie, Terry, Paul, thank you as always for an outstanding session. And remember, as I said, be good to yourself, but more importantly, y'all be good to each other. Take care.